So good evening everyone, and we are going to discuss the ophthalmology NEET PG 2025 questions. So as we had seen that this time the paper was moderate to difficult. Nobody said that it was easy, but yes, some people said that it was moderate, but some people said that it is difficult. So I think this difference came because the options were quite tricky. They were very close to each other, and the questions were also long clinical scenario type. So very few one-liner questions. But the good thing is that the questions were from PYQs, from PYTs, and from the important topics. So what do you say? Please comment in the chat section that what is your opinion about the format of the question paper, time management, was it lengthy, was it easy, was it clinical, and what were the subjects that formed the major chunk of the paper. So based on that, we will be discussing this. So let's get started with this question number 1. Now this is based on the recall, and I had tried to specify what were the most important things in the question, on the basis of which we can rule out the other options too. So if you look here, you can see that they had given an image something like this, and they said that this image is slowly growing, it is painless, and it is in the 15-year-old child, and number 4, it is from past 1 decade. Now when I am saying that it's a slowly growing one, it is in 15 years, it is this painless, and it is from the past 1 decade, then obviously I can rule out the lacrimal gland. It's not the common one, and moreover there is a confusion. Some people said that it was a lacrimal gland tumor. If it was tumor, then also you have to rule it out, and otherwise also if I have to compare between a normal dermoid cyst and a lacrimal cyst, so it is actually the dermoid cyst that is the most common site. Osteomas and hemangiomas can be easily ruled out. So in all the questions, or almost in all of the questions, the two options were very close to each other, and mainly you had to struggle to rule out the one. Now they had clearly said that it's slow growing, it is painless, it is in 15 years, and it is 1 decade. So you can easily rule out the lacrimal one and go with the dermoid cyst. Now second important thing is that dermoid cyst is again in their mind from the last 2 years. In NEET PG 2023, in NEET PG 2024 also they had given a question on limbal dermoid. So that was a limbal dermoid, this is on the dermoid cyst. Alright. Now second question. Now this is a kind of a question that we have done so many times in the classes, and I had told you also that Ectopia lentis. Ectopia lentis is a important topic that you must go through from the lens. And second thing that I told you, that it is not per se the cataract that may come, it is the systemic associations. I told you that it is the inset PYQs which are more important for the NEET PG now onwards than the NEET PG PYQ itself. Why? Because NEET PG people have also started asking related to systemic associations, and they are not asking you the core ophthalmology now, and that is the reason that the inset PYQs are even more important for NEET PG than the NEET PG PYQs itself. Now this is a boy who is again 10 years boy, with the blurring of vision, with the high-arched palate, joint hypermobility, long fingers, and they are also, on our examination they had given a slit lamp picture. Now some of the students said that they had not given this any slit lamp picture. Some of the students said that the picture was there. So you will have to comment that whether the picture was there or not. But if I am saying that there is a tall limbs along with the arachnodactyly, high-arched palate, so definitely it can be a case of Marfan syndrome. Okay, now yes, you can think about the homocystinuria also, but the important thing is that Marfan syndrome ka defect they have given, but they have not given you any defect of homocystinuria. Homocystinuria, if it would have been, then we will get the deficiency of cystathione synthase enzyme. So you do not have this, therefore no confusion, and you can easily go with the fibrillin gene defect Marfan syndrome, where we are having the supratemporal subluxation. Homocystinuria mein we have inferonasal subluxation. Then we can have what you call as Ehlers-Danlos syndrome, we can have Weil-Marchesani syndrome, and all the four are very, very important as the causes of the Ectopia lentis. So what is Ectopia lentis, guys? Ectopia lentis is actually the subluxation. Whenever we are having the subluxation of the lens is not present at its normal position, then that is called as Ectopia lentis. Now, if the lens is moving from its position, we are having the subluxation. First of all, you should know what is the difference between subluxation and displacement. What is the difference between subluxation and the displacement, guys? It is the partial displacement. Whenever we are having the partial displacement, then that is called as the subluxation. Now we can have different kind of subluxations, like in cases of the Marfan syndrome, it is the supratemporal, that is superior and temporal, while in cases of the homocystinuria, in the cases of the homocystinuria, we are having inferonasal subluxation. Then number 3, we can have the Ehlers-Danlos syndrome. This is also having subluxation, but there is no particular direction. You are getting also the blue sclera. And 4th is the Weil-Marchesani. All 4 are important. Weil-Marchesani syndrome. 4th is the Weil-Marchesani syndrome. In the Weil-Marchesani syndrome, we get the subluxation which is antero-inferior. Along with this antero-inferior subluxation, we are also getting the microspherophakia. Microspherophakia. Micro means small, sphero means spherical, and phakia means lens. We are having small and spherical lens, and even this can also come as a question which is having the systemic association along with the eye involvement. Like along with the subluxation, you can get the short stature. This is a child with a short stature, and also we can have the brachydactyly. Brachydactyly. What is brachydactyly? Brachydactyly means we are having the short and the broad fingers like this. Like there we were getting the arachnodactyly, here we are getting brachydactyly. So whenever you are getting in child short stature, brachydactyly, microspherophakia along with the antero-inferior subluxation, it is Weil-Marchesani syndrome. Another important thing is the aphakia. Whenever we have Ectopia lentis, we have subluxation of the lens, we will have aphakia. Part of the lens has moved, so some part can be having phakia, some part is having aphakia. Part which is not having the lens, from where the lens has moved, that part is aphakia, for which the person can also be using the spectacles. So they can give you in the question that the person is using the aphakia spectacles. So that is also evident that this is a case of the Ectopia lentis. Is it clear, guys? There will be proptosis in the lacrimal gland. So lacrimal gland wale, if first of all in early stages they will not lead to proptosis. In the later stages they will lead to proptosis, and that will always be non-axial type, eccentric type of proptosis. Okay, is that clear, guys? So shall we move to the next one now? Next is this. This is also a repeat PYQ hai, and let me tell you that this was an inset PYQ, and this again proves what I told you, that inset PYQs are even more important for NEET PG now. So this is actually index, what you can see, which we have read in the Keratoconus, if you remember. This is the intrastromal corneal ring segments. Intrastromal corneal ring segments hai, which are helping in the flattening of the flattening of the cornea. Okay, so the answer of this question is the keratoconus. So whenever we have, the conical protrusion of the cornea, that is keratoconus, that can lead to the myopia. And for myopia, we will do the flattening of the cornea. Therefore, answer to this question is keratoconus. Apart from this, everything about keratoconus is important. If you see, when we talk about keratoconus, even the pantachem is also important related to keratoconus. So instead of a normal cornea, the cornea is like this. So what is happening? We have uneven surface. This person will have uneven surface. And if you look at the axial length, look at this and look at this, you are also having the increased axial length. We are also having increased axial length. So due to uneven surface, we are having the astigmatism, and due to the increased axial length, we are also having the myopia. This is the refractive status of this person. Along with this, the signs of keratoconus. What are the different signs of keratoconus? Keratoconus may, I can get the tip of the keratoconus. This is seen as the oil droplet reflex. This is seen as the oil droplet reflex. Then a very important ring is there. That is called as the Fleischer's ring. That is called as the Fleischer's ring. Fleischer's ring is different from KF ring. KF ring is seen in the Wilson's disease, that is due to the copper deposition. This is Fleischer's ring, which is due to the iron deposition. Due to the iron deposition. Then number 3, we also have what you called as the Vogt stria. Vogt stria, V for Vogt and V for vertical. V for Vogt and V for vertical. We are having the vertical striations here. Where do you get the horizontal striations, guys? Like H for half and H for horizontal, they are found in the congenital glaucoma, the ophthalmos. Then we also have the scissor reflex. We also have scissor reflex. Scissor reflex is found on the retinoscopy. This we are getting on the retinoscopy, which is due to the astigmatism, because this person has the astigmatism. Due to this, we have the scissors reflex. And then we also have the Munson sign. Then we also have the Munson's sign. In the Munson sign, what is happening? Because we are having the conical apices of the cornea. So when the person is looking in the downward gaze, we have the localized bulging of lower lid like this. Localized bulging of the lower lid. So this localized bulging of the lower eyelid, when the patient looks down, that is actually called as the Munson sign. Treatment modalities. Now because cornea is conical, so I have to give something which can replace the surface of cornea. So for this, I can give contact lenses, that is rigid contact lenses. We can give the rigid contact lenses. We can give intakes like they have given here. We can implant this, which are causing the corneal flattening, something like this. They are doing the corneal flattening. And number 3, we can give the topical riboflavin. We can give the topical riboflavin drops. These drops are actually helping by preventing the progression. How they are preventing the progression? By causing the cross-linking. So because they are causing the cross-linking, there is no more progression. And finally, if nothing helps, then you can go for the corneal transplantation. Then keratoplasty or the corneal transplantation. Alright. Then coming to the next question. So this question is about the orbital cellulitis, and we know that orbital cellulitis is the most common cause of unilateral proptosis in children. So they are asking what is true. So the first option is that inflammation is anterior to the septum, which is actually false. This is a false statement, because the basic difference between the preseptal cellulitis and orbital cellulitis is this only. When it is present anterior, then that will be called as preseptal. then that is called as the preseptal cellulitis. And when it is present posterior to the septum, then that is called as the orbital cellulitis. Then the second option is topical antibiotics are given. So they are not given topical, they are given IV, because it is a kind of emergency condition where we are having the most common cause of unilateral proptosis, that too in children. Most common cause of unilateral proptosis in children is the orbital cellulitis. So you have to give the IV antibiotics. Ethmoidal sinus infection is involved in all ages. Okay, clinical features of proptosis are there: decreased vision, that is true, this much is true, but normal eye movements, normal pupillary movements is wrong. So overall the true statement will be C only. Overall the true statement will be C only. Now sometimes what they are doing, they are giving the partially correct statement. So if that statement is partially correct and one statement is totally correct, then obviously you have to prefer the totally correct statement. Is that clear, guys? Is that okay for you? Then coming to the next question. So they have given an image something like this. Like some people said that instead of the parrot, it was a dog or a rat, something like this. So this I always tell you in the class also, that if I take the bird in one hand and the cage in one hand. So if a patient is shown the bird in one eye and the cage in another eye. Cage you can take, house you can take, and bird ki jagah you can take any animal also. So we are talking that when the one single person is seeing one image with one eye, another image with one eye, and finally if he is not having squint, he will be seeing something like this. He will be seeing both the images simultaneously, because retina is doing simultaneous perception. So that means both cage and the bird are seen simultaneously. This is not fusion. And if the patient has squint, then this simultaneous perception is not possible, because both the eyes are not in alignment with each other. So this is called a simultaneous perception. While second is fusion. Fusion is always taking in the similar images. Now these images are similar, but both of them are incomplete. This is also a rabbit, this is also a rabbit, but one is having a tail and one is having the flowers. So two similar images, both are incomplete, they'll fuse, they'll combine to form one complete image, which is having a tail also and having the flowers also. That is actually the concept. So whenever you see anything, whenever you see any object, then the image of that object is formed in retina of both the eyes. So first there is a simultaneous perception of both these images. Okay, this is the first step, simultaneous perception. Now if both these images are similar, then there is fusion. So both these images will fuse. Okay, and once they have fused, then only we have 3D perception. This is the final outcome, and how you see only one single image. That is why the answer to this question is this. Image 1 is simultaneous perception, second is the second is the fusion, this one, and the second is the fusion. First is simultaneous perception, second is fusion. We have three grades of binocular single vision. Can you name any test of binocular single vision, guys? Any test that we can do for binocular single vision? Like one is simultaneous perception, that is there, and number 2 will be the fusion. Fusion will be of two similar images, and number 3 is the stereopsis. Number 3 is the stereopsis. Okay. And the next question, a patient is diagnosed with a bullous keratopathy and the guttata also. Now, whenever I am talking about the bullous keratopathy, bully, that is always related with the corneal endothelium. That is always related with the corneal endothelium. And out of these, which dystrophy is actually associated with endothelium? That is the endothelial dystrophy. This is the most common dystrophy also, which is found in endothelium. That is why the answer to this question is the Fuchs endothelial dystrophy. So don't get panicked because the question comes from corneal dystrophies. I told you also that they are either asking most common or least common, just that. Okay, not many dystrophies are asked. And apart from this, if you look at the other options, they are very clear cut. If you see cytomegalovirus, so that will be causing CMV retinitis. This is the most common infection in a HIV patient, which is causing CMV retinitis. Cotton wool spots hai. Herpetic keratitis mein you should have dendritic ulcers. So even if you do not know the direct answer, then also you can come out. And trachoma mein we will have the sago grain follicles. We will have the sago grain follicles in this patient along with the papillary. Along with the papillary hyperplasia. Along with the papillary hyperplasia. Okay. Then coming to the next question, this. So this image I think was there, but I do not know what was the exact language. Most probably these two things I came to know, that this patient was an old patient, diminution of vision is there, and you can see some dandruff like material. Dandruff like material was there, and they had asked for the spot diagnosis of this. So one is the pseudoexfoliation syndrome, which is the most common secondary open angle glaucoma, which is the answer. But I do not know what were the other options. One was glaucoma fleccens. Glaucoma fleccens was there. Then number and 3 and 4 also I do not know what was the option. Keratoconus, isme keratoconus was there. What was the other option? Fourth option, can you tell me what was the fourth option? Like if I then maybe trachoma or iritis, there was confusion, but answer, there is no confusion. Answer is the pseudoexfoliation syndrome only. So these were the questions from our side in NEET PG 2025 ophthalmology. Iris related, some option was there. So please let me know in the comment section if any of the options you come to know, if any of the questions that you get reminded even after the session, any image you want to relate, then you are most welcome, and I would be very happy to modify the language of the questions, and we have tried to come up with the most accurate questions, images and the options. You can connect with me on Instagram, Telegram, Facebook. You can DM me, you can follow, and you can follow the YouTube channel for the further videos. You can always interact with me on the DMs, which you can do on Instagram and Telegram. So thank you so much guys, and be motivated, trust on yourself, and keep smiling. Happy ophthalmology. Bye bye.